absolute thrill to be here. And I've given a few talks before, both as a resident here, learning how to give a talk, and a few outside of the institution. And to be totally truthful, this is the one that terrifies me the most, because I'm in the room among friends, and these are people. You are all people that I care about so deeply, and you know, this one gives me the jitters. All right, so moving forward. Every good talk starts with a selfie, right? So there I am. Okay, fine, I wish. But truthfully, I don't have any financial disclosures. I do have one thing to disclose though. Today I'm talking about a women's health issue. And in our current political and social climate, I have to say that we need to advocate for those who need our help. And certainly this is a time where we all need to be advocates for women's health. So let's go onward with that. So every talk in emergency medicine, well, every half-decent talk, starts with a story. And when I was thinking about a story to tell, I was thinking, my God, after 4 years in residency here, I've accumulated so many stories. And a lot of the people in this room know some of my stories. I thought about, I want to talk about a women's health issue. Should I tell about the night when I was an intern? We were in the A-pod on the front side. Dr. Willis, Jimmy was my senior, he was the chief that year, and one left enrolled in this lady, and she was dying. And obviously I had no idea what was going on, but Dr. Willis stepped right in and coached me through it, and really she was dying from a ruptured ectopic. But that's low-hanging fruit. So I'm going to tell a story that I accumulated this year. So get your box of tissues, because here it comes, all right? So this story starts in January. It's a story of a 35-year-old female, recently married, very happily married. She's G0, P0. Her preferred method of contraception is a copper IUD, and she trusts that IUD so faithfully that she doesn't pay attention to whatever's going on in her life. She doesn't know when she's had her last period, whatever. I judge those people, but I no longer judge. Anyhow, she's feeling a little weird. One day, and she noticed she was spotting a little bit, which wasn't normal for her. So she decided to take a pregnancy test. Conveniently, she's an emergency doctor, she's at work, so she just, takes one off the rack, goes to the washroom, does her thing, and it's positive. So what does she think to herself? Oh shit. And just to echo what I heard from the front row here. Thanks, Melanie. Oh shit. All right, so again, conveniently, she's an emergency doctor, so 2 hours later, as she's fumbling through the next set of patients, she goes back and takes another one. Okay, it's positive. Oh shit. All right, and again, like every good emergency doctor, she runs into a GYN room and is frantically trying to sono herself. Do I see anything? Do I not see anything? What is going on here? Okay, that was a complete failure. Then, this 35-year-old emergency doctor is like, oh God, what do I have to do now? Oh God, what am I gonna do? So she swallows her pride, walks over to one of her quite new and respected colleagues and says, I got a bit of a situation on my hand here, and I was wondering if you could help me out. So thankfully it's her trusted co-fellow, and they go into the GYN room. They do a endocavitary transvaginal ultrasound, and what do they find? Uterus, no free fluid, the shiny stripe of an IUD, and no sign of a pregnancy. Okay, let's pause the story here. Actually, let's not pause the story here. So what does she do? Besides say, oh God, I have 2 hours left in my shift, I need to get home now? Or does she think smartly and does what y'all are going to do? So somewhere halfway in the middle, she finishes her shift, signs out, draws a serum beta HCG, and runs the hell right out of there. Get home, just get away. All right, story paused. So why are we talking about this? It turns out that ectopic pregnancy is a very important disease. It's a very important disease because people die from it. And why is it important to you? It's important to you because you're going to see it. The data is variable, but about 2% of all pregnancies are ectopic, and about 10 to 15% of the patients that we see with first trimester bleeding in the emergency department, they're gonna have an ectopic. So if you're not seeing ectopic pregnancies, or you haven't, thank goodness Dr. Sinnert's here, you're just not seeing enough patients. Or you're missing them. So hopefully in the next 30 or so minutes, we're going to help you identify who's got an ectopic, why they have it. We're going to talk about the core content, the basics, how you're going to work these patients up. We'll talk about 2 special situations, and we're going to hedge our way into a strange category, a diagnosis called pregnancy of unknown location, and we're peppered in the middle. We're going to give you 4 hard stops, things that make you go, all right? Things that should make you stop what you're doing and think carefully before you move forward. At the end of this, you're going to see that patient with vaginal bleeding on the board, and you're going to say, oh, I got this. You're going to pick them up. You're going to know exactly what to do. You're going to figure out, you're going to know exactly who's high risk and low risk for getting really sick, and you'll be able to offer meaningful counseling to our patients. So, positive UCG, someone's bleeding. Like every single patient we ever see in the emergency department, you're going to either consciously, as you're learning through PGY 1 and 2, or subconsciously to the people who've been doing this forever, you're going to decide, are they sick or are they not sick? All right? Are they stable or unstable? Easy. If they're sick, if they're unstable, do what you've been put on this earth to do. You resuscitate them, just like the monsters that you are. So in these patients, that's going to mean great vascular access, it's going to mean blood, and getting their definitive management. And for these patients, it usually means a gynecologist and an operating room. Simple, right? Let's go home, right? But those are just the sick patients. What about others? What about all the patients who are not that sick? You're staring at them, they're staring at you, and it turns out that you just got to work them up, okay? So you work them up like you work up most patients. You take a history, you do a physical, and you do an ultrasound. In pregnancy, in the emergency department, the ultrasound is essentially an extension of our physical exam. I'm going to say that one more time. If you see a pregnant patient in the emergency department, the ultrasound is an extension of our physical exam. You're going to do the ultrasound. It's going to give you the information that you want to do. And not to belabor any points, there has been sort of mixed literature, what's an IUP, what isn't an intrauterine pregnancy. For our situation in the emergency department, and every practitioner, safe practitioner of emergency medicine, an intrauterine pregnancy is defined as a central, sometimes fundal gestational sac, a yolk sac, and a fetal pole. A live intrauterine pregnancy is that same gestational sac with a fetal pole and visualized cardiac activity. Okay? I'm not going to belabor the ultrasound anymore, what it is or what it isn't. And this is what brings us to our first hard stop. Our first hard stop is get really good at sono. Get really good at pelvic sono. But in that same breath, know the limitations of your sono. This is not the time to say, oh, I think I saw a little schmutz over here. No, we're not dealing with schmutz. You either see the IUP as we've defined it, or you don't. All right, so you've done your history and your physical and you've done your sono. How important are they? So this comes from JAMA. It's my, I don't want to say the best because that's very polarizing, but it is my favorite series of papers. It's the Rational Clinical Exam. Y'all should read them. There's one, does this patient have CHF? And it helps us answer that question. This is a beautiful one. Does this woman have an ectopic pregnancy? And basically what it does is it's a systematic review of 14 articles, and what they do is they gather all the data and they help us decide what information is contributing to our diagnosis of ectopic pregnancy. So, interestingly, the history, Like, oh, I have some cramping. Oh, there's some bleeding. Oh, I have back pain. It only has a positive likelihood ratio of 1.5. So essentially, the history isn't going to tell us what's up. Then you do your physical exam, you push on the abdomen, you check, you feel an adnexal mass, you don't feel an adnexal mass, they have bimanual tenderness, CMT, all of those important physical exam maneuvers. Are they going to give us our diagnosis? No. No. The negative likelihood ratio of a normal physical exam is approaching 1. It's totally equivocal. And then we get to the transvaginal sauna. If you see an IUP, the patient doesn't have an ectopic. If you see an adnexal mass, a complex adnexal mass with surrounding free fluid, if you see a ring of fire, if you see that, you have a diagnosis. So the bottom line, I'm sorry that I'm really beating this to death, but the bottom line is ultrasound is king. Okay, great. Ultrasound is king, so we do the history and physical, which we have to do for every patient to gather important information, but it's not going to make our diagnosis. We do the ultrasound. So we do an ultrasound, and boom, we don't see an IUP, but you see some free fluid. So that brings us to our second hard stop. Should you take nothing away, it's these 4 hard stops. Hard stop number 2. If you don't see an intrauterine pregnancy and the patient has free fluid, they have an ectopic pregnancy until proven otherwise. This is not a patient that you say, oh, they look fine, oh, their belly's not tender, we'll just send them home, blah, 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 beta this, beta that. No. This is an ectopic pregnancy until proven otherwise. So much so that this ultrasound exam needs to include the fast views. One of your colleagues, Jackie Shibata, was just doing some work in Botswana where she saw loads of ruptured ectopics, and many of them, when she did an ultrasound, had no fluid in the pelvis because they were laying flat because of their position, because of their habitus, etc., but they had a huge stripe in Morrison's pouch. Don't be fooled. All right. Yes?
Just, there were 2 actually ruptured ectopics that I found just off of fast views.
Just off of fast views. Don't forget your fast views.
Young female in extremis fast.
You got it. No IUP, positive free fluid, it's a ruptured ectopic. All right.
Sally,
Yo.
going back to your likelihood ratio on the transvaginal ultrasound, do you know if that data is based on radiology techs or ED attendings?
Great question. These 14 review articles were taken from a variety of studies. Some of them were radiologists, radiology sonologists. Some of them were OB sonologists, and some of them were EM. But there are other studies that showed just fine that with good training, an EM sonologist is just as good as any one of those. When I talked about the limitations, we'll briefly touch on this at the very end, but you also have to know the limitations of your equipment. Because the ultrasound machine that we use in the emergency department are not the same as ultrasounds used elsewhere. But if you see the IUP as we defined it, it's an IUP. If you don't see that, it is not an intrauterine pregnancy. All right, allons-y. So we beat that up. Don't miss the ectopic. All right, so then you have this patient, they're bleeding, they're pregnant, and you see an IUP. You see exactly what you need to see. Then what? What are you gonna do next? What are you gonna do?
And make sure it's not a heterotopic.
Okay, you should make sure it's not a heterotopic, absolutely. All right. Where's I saw Guy Carmelli in the crowd. I can't wait for you to fight me on this one. So then, you do the pelvic exam. Who's read an article in the last 4 years that says, oh, the utility of pelvic exam in the emergency department is questionable. It doesn't provide that much information. No, we don't really need to do it. Raise your hands real high if you've read those articles. Do you believe them? Of course you do. Of course you do. All right. All right, haters in the crowd. Who does think that you need to do a pelvic exam on these patients where you see the IEP? I see a lot of ladies' hands in the air. All right. So I'm about to break those articles to death. So ears open. I saw the Jarrett 2 crowd over there with their hands up. So does pelvic exam in the emergency department add useful information? This is a prospective study, 183 patients, and saw patients with GYN complaints, pelvic pain, bleeding, etc. Some were pregnant, some were not. And of all those people, they did the history and physical, and they made a prediction. I predict that the pelvic is going to show this. They wrote it down. Then they did the pelvic exam, and then they compared. And what they found was, in 70% of the cases, their prediction was absolutely bang on. In a little more than 20% of the cases, their prediction was not right, but it really didn't change the management. And only in about 6% of these patients did the pelvic exam change their management. Okay, that's great. Who read that study and who's basing their decision to do a pelvic or not to do it on that? Anyone? Anyone? No one's great? They didn't include patients for which you were looking to see if they have an open or closed os or products of conception. So throw it out. You need to do the pelvic exam. Same, the famous Al Sacchetti did a similar study, and he also found that you don't need to do a pelvic exam if you have a normal bedside ultrasound, but at the same time, they excluded patients that had any sort of cramping, and they excluded patients that had any period that the patient defined as any bleeding that was defined as slightly more than their regular period. I think that's lame. This is the lazy way out. Bottom line, do the pelvic, finish your exam. Okay.
There's one argument against it, though, which is if you have a positive IUP on ultrasound, a little bit of bleeding, to do pelvic examination is actually the opposite of what you recommend the patient to do, which is pelvic rest, to stimulate the cervix. If the patient has a potential for abortion, then you might stimulate that.
That is true. That is absolutely true. However, I think you should look. This is why I think you should look. You know, I'm not saying jam the speculum in and beat the cervix to hell. I'm not saying that. Just have a look. You know, one of the more humbling experiences of my life is when I called GYN to come down, and because I said, oh, I think this patient has an ectopic, and they examined the patient and the products of conception were in the vault. And I was stupid and I looked like a dummy, and nobody should feel that stupid or look like a dummy. Just look. You don't have to use a speculum. You can even just look. Do a very gentle digital exam, but figure it out.
You're probably not going to see much if you don't use a speculum. And if the cervix is that sensitive, you're probably going to have a hysterectomy anyway. I mean, eventually this woman has to carry for the next 9 to 10 months. Her cervix is going to get stimulated. So,
Yeah, I don't
say
think
how, but
I don't think pelvic rest has ever been proven to actually prevent miscarriage.
Yes.
So, I mean, or bed rest. So, I mean, we recommend it because we're not going to
Exactly.
stop that, but it's never been proven to be useful. So, I don't know that.
So what I'm advocating for, I know there's a study to tell us to do everything on both sides of the train. What I'm advocating for is do a pelvic exam. Just have a look. All right, next. Now we're going to enter into a slightly more controversial territory when it comes to management. Well, one thing's controversial, one's not. But let's talk about the pregnant bleeder who has a positive UCG. They have no free fluid, but you don't see that definitive intrauterine pregnancy. What to do then? All right, what are you going to do? A beta. I love this. So good. The famous beta HCG. All right, famous beta HCG. Who's brave enough to tell us what this beta HCG is going to tell us in the emergency department?
Not much definitively.
Genius in the corner. Dr. Brian Jarrett. It's not going to tell us anything definitively. You need to get the beta because it's going to help in the overall management of the patient. But it doesn't matter if the beta is 50, 500, or 5,000, it's not going to give us our diagnosis. It's just not. How do I know? Okay, I love this article. It's another review article from the New England Journal of Medicine, and basically what they're talking about is the impetus for this research project is that a lot of gynecologists were feeling that they were sort of prematurely offering uterotonic agents and cytotoxic agents to patients when they weren't 100% sure exactly where pregnancy was. And on one hand, okay, better safe than sorry, but on the other hand, there are a whole lot of people who have this highly desired pregnancy and we don't want to terminate if they don't need a termination. So that's the impetus of this article. And the part of it that I want to bring up in particular is there's a special section for pregnancy of unknown location. And I've heard lots of gynecologists say, you know, I don't see the intrauterine pregnancy, I don't know where it is, it's probably not in the right place and you're at risk for serious hemorrhagic complications. I think we should offer treatment. But they're not sure. Based on your beta HCG, you know, we expect to see something, but no. What this review article found is that there is a tremendous amount of overlap between beta HCG in people that have a viable IUP. 2% doesn't seem like a lot, but it's not an acceptable miss rate. It's not acceptable for us to say, you have a 2% chance. If it's a highly desired pregnancy, I don't think that's an appropriate discrimination to make. And there's a tremendous amount of overlap for beta HCG for people that have a non-viable IUP or an ectopic. So hard stop number 3 is there is no single value of beta HCG that's going to give us an answer. It is completely meaningless unless it's 0. Caveat and side note, if the beta HCG is like 5 zillion, that could be an indicator of a different kind of disease, like gestational trophoblastic disease, but very rare. Just keep that in the back of your mind, but really, a single serum beta HCG is completely meaningless unless it's 0. Does anybody disagree with that? Thankfully, we have college to back us up. So in 2003, 2012, and recently reprinted in 2016. It's actually 2012 is the official policy, and in 2016, the American College of Emergency Physicians, based on a review of the literature, put out this policy. And basically, they also say that there's no single beta HCG that's going to give us a diagnosis. Throw out your idea of discriminatory zone. It's gone. It's completely meaningless. All right. So we're back here, and we're still here, and we don't have a definitive IUP. The patient doesn't look sick. They don't have a tender belly. They look pretty darn well. So now what? I've already told you that the history isn't going to give you the diagnosis. Your physical exam certainly isn't going to give you a diagnosis. A single beta HCG is not going to give you your diagnosis or exclude anything. And the ultrasound, where we're going to put our money, where ultrasound is king, it's non-diagnostic. So we're nowhere, right? We're absolutely nowhere. So now I'm just going to stop and take a moment and say that I'm going to discuss something that I don't want to say is a little bit controversial, but I feel like administrators and independent practitioners feel differently about this. There's a high amount of variability between practice environments, but I'm going to talk about pregnancy of unknown location and what are some options that we as emergency doctors can do. So we can see what the beta HCG is, but we already said that's not helpful, so just cross that one off our list. We can do an official sono, and depending on where you work, could take 1 to 6 hours, depending on what time of day, depending on if it's a weekend, etc. Where I currently work, there's no such thing as an official sono. it's my sono and the GYN resident, hopefully attending, comes down, sono. There is no sonologist, okay? So, or here you could get an official sono. You could get an official sono and call GYN. And now I'm going to introduce 3 more touchy topics. Could you discharge the patient? They're well, their belly's not tender, you don't have a diagnosis, or you do have a diagnosis, but you don't know if it's ectopic. It's a pregnancy of unknown location. You could discharge them with follow-up. It depends on the patient, or it depends on your local custom. And that's a very important concept to keep in mind. You have to practice within the normal of the environment that you're working in. And that's going to change. What's normal here is going to be different than what's normal in the community. And what's normal in the community is going to be very different what's normal on the West Coast. And what's normal on the West Coast might even be different if you work for a private group. So, I'm advocating for following your local rules, understanding the patient's ability to understand the possibility and depth and breadth of their illness, and of course following the local custom. So, we sort of touched over this. So where I was a nurse in Canada, there's no such thing as an official sono. We saw these patients in the emergency department. They got a cursory sono. This was in like 2002 when emergency doctors were sort of really just getting into it and just honing their skills. All the patients that weren't sick got discharged, and they came back in the morning for a real ultrasound to an outpatient facility. We never saw them again. That's okay. All right. The point I'm trying to make is that in the emergency department, when we see these first trimester bleeders, there's a very good chance that we're not going to have their diagnosis on that first visit. There's a very good chance. In fact, most of these patients don't get treatment or have definitive management after a first visit. It takes time. So I'm arguing for, if we know they're going to need a second visit and they understand the depth and breadth of their illness, why not discharge them? They can take some responsibility for their health. Is that so? You talk to a patient, they verbalize their understanding, they either have a gynecologist that they have seen in the past or that they're currently seeing. You can maybe get in contact with them and say, hey, I've got your patient, they need to see you tomorrow. Does anybody feel like this is crazy?
I don't think it's crazy. I think that, as you said, it's the environment. So here, the problem is to get the appointments, right? To get the 2-day appointment, the 3-day appointment, it can be very difficult for our patients. For us, many of the women in the room have a gynecologist. You can just call your gynecologist. So it's the setting that's the difficulty in getting the appointment.
Absolutely. If this is a patient who you're diagnosing their pregnancy in the emergency department, it's as much of a surprise to you as it is to them. It's their first pregnancy. They've never seen a gynecologist before. This is not the patient to just say, see ya, follow up. I'm not sure that they're going to get it. Ask a patient, do you have a gynecologist? Are you seeing somebody for this? And if they have someone, it's okay. So just like Dr. Smith said, it depends on the patient and it depends on your practice environment.
All right, I think coming back to the emergency room is also an option, right? I mean, it's still better than admission.
So some of the best advice that I've ever been given by one of my seniors counseling me is by Dr. Willis again when he was the chief resident. Oh, what do I do with this patient? Oh my God, what am I going to do? Just tell them, come back. We're happy to see you again. All right, let's put this all aside and get back to our story. So I went home from my shift and I had to tell my husband, I was like, all right, we got a situation on our hands, what's up? And then, a couple hours later, my co-fellow calls me and says, hey, I just got your beta back, it's almost 5,000. And I was like, huh, that's interesting. Then I remember, right, a single beta is meaningless, I don't know what this is. And she judged me to be fit to follow up and to understand the return precautions. So I went about my business, I followed up the next day. and I went to a sono center that had an ultrasound that would make you all drool. The radiology tech and the radiologist and the gynecologist all said, you know, this is the Rolls Royce of ultrasound. That's exactly how they described it. And that's what I meant when I say, know the limitations of your skill and your equipment. It just like, what we see as like shades and shadows on our bedside ultrasound and convincing ourselves that it's clear images, no. Their version of that was like a Monet. I swear to you, it was incredible. Anyway, so I went for a formal sono, and what it showed was an empty uterus. You can see the arrow points to the appropriate endometrial cavity, and there were not one, but two gestational sacs that appeared to be in the endometrial cavity, but were cornual. So, cornual ectopic pregnancies. Don't be fooled. They look like IUPs. They look startlingly like perfectly healthy fundal IUPs. They're not that common, but they're real, and it is an ectopic. All right. So I got a shot of methotrexate, I went home. It took a really long time for the beta to fall, and that is normal. And that's the resolution of this discharge and follow-up ectopic story. Next, let's talk about two special situations. Special situation number one. Anybody who is undergoing any fertility treatment, whether that be pro-ovulatory agents like clomiphene, whether it be ovarian hyperstimulation by hormones, whether it be direct embryo transfer through IVF, all bets are off. Do not discharge these patients. They need to see a gynecologist. They need to have a diagnosis or close to a diagnosis before they leave. They need a specialist. Is that clear? If someone's getting fertility treatments, forget the last 40 slides. Call the gynecologist. Forget your pride. There's no room for pride here.
So if you're in a place that has no OBGYN, are you admitting these patients and then what?
So that's a great question. These are patients that have spent tens and thousands of dollars for their fertility treatments. They all have a card, they all have a number to call. There's always either a PA or a nurse practitioner or a gynecologist on call. It's our job to get in touch with them. And they usually have an appropriate plan like, oh, I'm at the office right now, send them. And that's a reasonable plan. Good point. There are lots of places that don't have OB. Eden.
So I have a patient with ovarian hyperstimulation syndrome.
Terrible disease.
When attendings did not feel comfortable taking the patient, so we ended up transferring them.
To where they were getting their treatments?
No, so they're actually from out of town. So we had to send them to the nearest center, which I believe was NYU.
Yeah, NYU. NYU has a big fertility treatment. It's a serious disease, and that's right. But these are patients that are going to need specialist evaluation. Okay, that was special situation number one. And then the second thing is, so if ectopic pregnancy is so common, and the push now is for stable patients to have medical management, you're going to see a few patients in the emergency department who have been treated with methotrexate or other cytotoxic agents for an ectopic pregnancy. If a patient has a known diagnosed ectopic, they've been treated with methotrexate or some other cytotoxic agent, and they're now in the emergency department with pain, they have a ruptured ectopic until you can prove otherwise. Look for the free fluid. It's going to be there. About 3.5 weeks ago, I saw this patient. She was diagnosed with an ectopic as an outpatient, treated as an outpatient, which is totally normal, and the GYN just kept, every time she went back, she kept going back for repeat betas. She was on her third or fourth beta. She'd gone from 4,000 to 500. She'd had one that day, actually. And her gynecologist said, if you feel sick, if you're weak, if you're dizzy, if you have pain, come back. And she was sitting at her dinner table, took one bite of food, vomited, and had pain. And she came back, she had tons of free fluid, and she went to the operating room. If you have a patient who's been treated with any cytotoxic agent for an ectopic pregnancy, they have pain or free fluid, they're ruptured. Call the gynecologist. All right. Are you guys exhausted? Are you bored? Was that too much plain Jane core content? Yes. All right. Let's switch gears for just a couple of minutes. And I wanted to talk a little bit more of the softer side of these patients. And having received lots of feedback on lots of lectures, nobody wants to hear the softer side. People want content. People want critical care knowledge. They want airway skills. But watch me, here comes the softer side. So, with these patients, you're worried about terrible hemorrhagic complications. The patient, however, is worried about the well-being of their developing pregnancy. It's this chasm of what you're worried about and what they're worried about that creates animosity in the doctor-patient relationship. That's what causes the misunderstanding, and that's often why patients feel so frustrated. And stepping back from the annoyances of day-to-day work, and if I really reflect on this, I would like to suggest that many of the dissatisfied patients that we have feel that way because they're concerned about one thing, yet we're barking up a totally different tree, right? In order to rule out critical illness and life threats. And what we need to do is narrow that gap. All we have to do is talk to them. This is where I invoke Jessica Stedz every day in my practice. Every day, with every patient that I see. Just talk to the patient. Find out what they're worried about. Explain what you're worried about. And help them. So if anybody needs little tools to counseling the patient, no one taught you in medical school, this is how to counsel a patient in every situation that you're gonna see. Actually develops over time, and it requires a lot of practice, and it requires modeling. Go to the bedside with doctors that you like, that you think take great care of your patients, and listen to how they talk to the patient. Has anyone ever heard Dr. Ectopic explain a patient's illness to them? Plain and simple. And at the end of it, everyone's satisfied. All right, I'm gonna give you 4 tips. This is something that I'm developing. I think it's my own original work, but I'm working on it, and I think I'm gonna try and present it to the residents that I'm currently working with. So, the 4 E's of counseling patients. Number 1, express empathy. Dr. G, be nice, right? That's just it. Be nice. Tell them that, express empathy, whatever that means for you. Some people do it differently. I'm so sorry you're feeling this way. This must be so stressful that you're going for this. Tell me, how are you feeling? Step 2, explain. This is what I'm concerned about. I'm concerned that you might have a developing pregnancy outside of the uterus. This can be very dangerous to your health. Okay, explain. Now we're narrowing that chasm between what you're worried about and what they're worried about. The third one might be the single most important thing you do in counseling patients. Manage their expectations. With all patients. With patients that are having first trimester bleeding and an indeterminate ultrasound, I tell them, there's a very good chance that I'm not going to have a clear diagnosis at the end of your visit today. We might not have a diagnosis. In fact, you're definitely going to need to follow up, and it might be tomorrow or it might be in 2 days, and it's going to be a bit of a process. You've managed their expectations. They know they're not going to walk out of there and know exactly what's going on. Have you ever heard a patient talking on the phone to one of their family members after they've received their papers? I've been here for 9 hours and they still can't tell me what's wrong with me. I've heard that, I can't imagine how many times. Manage their expectations. There's a very good chance that we're not going to have the diagnosis today. It's going to take several days for us to get there. And the last thing is emergency. Tell them what's an emergency. Tell them when they need to come back. and make sure that they're able to articulate to you why they need to come back, okay? For example, in this case, weakness, dizziness, fainting, bleeding, worse pain in your abdominal area, feeling like your heart's racing, vomiting, right? Those are all good reasons to come back. So putting it all together, you've expressed empathy, you explained the problem, managed their expectations, and told them why they need to come back. And this can be extrapolated into every single patient that you see, and should be extrapolated into every patient that you see. The count, you know, who cares what the patient's CBC is in 2/3 of your patients, right? The most important thing that you're gonna tell them is you're gonna give them good counseling. All right. That draws us to the end of the boring, oh God, not another GYN lecture portion. And I just wanna, I was sort of suggested to tell a story about my time in residency after I finished the sort of core content of my lecture. And interestingly, because I just graduated, I'm a brand new fresh grad, most of the people in this room know my stories. Remember the Crike? Does anyone remember Crike Day? Worst day ever. If I never have to do one of those again, I'll be okay. And the reason I'm not going to tell a story from residency is that I feel like the last 10 months, the last 11 months, have really just been an extension of residency. And I feel like I'm still a resident, and I feel like I'm still a Kings County resident. And that's a different thing. That means showing up early, it means working hard, it means taking care of patients that really need our help. And I hope that in my career, I feel like that every day. So, as an extension of my residency, I need to call on the people that I know and love, that trained me, that taught me what I know. And I do it with almost every case I see. For example, Christmas Eve, right? The brand new sucker gets to work on Christmas. It's about 9:30 p.m. An 86-year-old lady comes in. She's being dragged by 2 family members. You know, she really started feeling bad after she put away her Christmas dinner. They put her on, check her vital signs, and I'm like, I don't care about her vital signs. She looked like death. She was pouring sweat, pale as a ghost, ice cold. They put her on a monitor. Someone does a 12-lead ECG. I'm at the bedside. I'm the only attending there. It's in the critical care area, and I'm looking at this lady, and these are the sickest patients that you're gonna see. Not the cardiac patients, the ones that are going to die if you don't do something, or if you do the wrong thing, they're definitely gonna die. And I think those are the scariest patients because it's your opportunity to save them, and if you screw up, it's your fault. Anyway, so I see this patient and I'm like, oh God, and like my heart is probably about that fast as well. And I think to myself, Aunt D'Souza, I all of a sudden forgive you for those 2 times that you made me cry. Sort of, but not really. What would you do in this situation? I need you. So I held my breath and I said, give 2 grams of magnesium, drop some midazolam. When in doubt, use electricity. When in doubt, use electricity. I don't know what fixed this. I don't know if it was the 2 grams of magnesium that they were still dripping in as the patient converted to sinus tachycardia, or if it was the 50 joules that she got under some sedation, very tenuous sedation. But keep him in mind. He might drive you crazy, but you're going to need him. So I'm in a medical education fellowship. I do a lot of program evaluation, residency evaluation, and look who I've become, Dr. Sinner. I wrote that in somebody's evaluation. They were slow as molasses. More patience, more learning. With that, I'd just like to give 2 messages. One to the graduates and one to the PGY 1s and 2s. So to the graduates, you are so lucky. You're going to go out next year, and I don't know if you've talked to many of my classmates, but we've all had situations where we felt in over our heads. Certainly the group of people that I've been talking with. And feel lucky and keep everyone with you. Keep their messages, keep their ideas, keep them with you, because in times of stress, you're gonna need Ian D'Souza in your corner. When you have a patient that's freaking out and emotionally distraught, you're gonna need Jessica Stess. When you need the calmest, coolest head, when it's really hitting the fan, that's when you invoke your inner Dr. Willis and Dr. Smith. That's when you do it. To the interns and second years, if I could offer you one piece of advice, don't get caught up in the daily annoyances. Don't be turned off by the endless logging of procedures. And don't gag every time you get an email, please respond to the survey. Just do what you need to do, shrug it off. What you need to know is that Dr. Lucchese has been right for years and will continue to be right. This really is the single best training program you could possibly be in. Listen, pay attention, participate, be active, and you're gonna come out of here a crazy good emergency doctor. And with that, I will take any questions, and thank you very much. Any questions?
Do you have any advice, like, for the corneal pregnancy, is there anything on ultrasound that really kind of lets you know this is not an IUD? Like, is it?
Great question. When you see you'll see the gestational sac, and it won't quite line up with the endometrial stripe. I'm saying that as somebody who's spent hours and hours and hours looking at ultrasounds of corneal pregnancies. I've never diagnosed one on my own. If anyone has anyone seen one? Or diagnosed it on their own bedside ultrasound? I think they're pretty hard to diagnose in general.
Yeah, I've seen one, and it was at an M&M.
So it looks like an IUD.
And I stared at that image, and I think I can still have it. It looks like a pregnancy. It really, really looks like a regular pregnancy. The only thing that you could say maybe is that the walls are a little bit thin. So, when you're looking at the gestational sac, you should see some sort of decidual changes. And those walls just don't look as thick as they should be, but it's very confusing. And it's oftentimes people end up saying, yeah, you need to There is, but we don't measure it though.
Right.
We don't go and measure the endometrial wall, the outer layer of the uterus. Even ultrasonographers, we don't go with it. We just do it by eye. So if you're not looking at it, it's oftentimes you will end up calling it an IUD. It's very subtle.
And it is super important to scan through the entire area because you can put the probe and you're like, oh, that looks like an IUD, and you see myometrium around it, it really looks like uterus. And then you scan down and then you see the endometrial stripe and you're like, oh no, that's the uterus. So you scan down, you'd be like, oh, IUD, I see a beautiful heartbeat, this is like, we're good, and you're not.
Yeah, and finding the cervix too, like making sure you guys, that's an absolutely great point. Because in that one case, once we saw where the cervix was going, we realized, wait a second, that's not in the, that's something's right, not right with that. So.
But you saw it in an M&M.
It was an evidence. So we were doing one year.
It's hard to diagnose. Any other questions about ectopic pregnancy, ultrasounds, like in general? I'm going to send you all out an email with some great data as well as a blog post from EM Updates, which is Ruben Strayer's blog. And there are links to several of these articles as well as a million other articles that it's a really good read, and it's definitely our bread and butter, so enjoy.